Hi, I would like to start by thanking the organizers of International Conference on Psychiatry. Good morning, good afternoon, and good evening, wherever you are. I am Nadia Arshad. I'm originally from Pakistan. I worked as clinical psychologist and research evaluator in College of Physicians and Surgeons of Pakistan before I was offered a Fulbright scholarship. I specialized in epidemiology from Karolinska Medical University, Sweden. Later, I completed doctorate in clinical epidemiology from Norway in the field of hematology and hemostasis. I have worked in various disciplines of epidemiology like infection, cancer, genetics, and cardiovascular epidemiology. Currently, I'm working as assistant professor and postdoctorate research fellow in reproductive epidemiology, Faculty of Medicine, University of Bergen, Norway. My talk today is about the recent advances and the future directions in psychiatric epidemiology using my current research project as an example. As we all know, research is an organized and systematic way of finding the answers to the question. In scientific terms, research is a process of systematic inquiry that involves collection of data, documentation of critical information, analysis of data, and interpretation of results in accordance with the suitable methodologies in order to answer the problem. These are the steps in designing and conducting the research. The research process begins with an identification of a problem. The next step is to understand the problem thoroughly by reading the literature and then phrasing the same into the meaningful terms. One of the best way to understand the problem is to discuss it with your own colleagues. Yeah. While selecting a research topic, one should keep these characteristics in front: relevance, avoidance of duplication, feasibility, acceptability, urgency of data needed, applicability, cost effectiveness, and ethical acceptability. Objectives are the statements that are measurable and that can be observed at the end of the research process. In simple terms, objective is what a researcher wants to do in the study. Always remember to use the concrete verbs and not the abstract ones while designing the objective. An objective should be specific, it should be measurable, achievable, relevant, and of course, time-bound. So these are some of the examples of the objectives, like to determine the association between mental health disorders and mortality among patients with COVID-19, to compare the effectiveness of cognitive behavior therapy and mindfulness meditation in patients with social anxiety disorder. In scientific context, a hypothesis is a tentable, testable statement about the relationship between two and more than two variables. It is also called an estimation prediction of the result. Hypothesis should be clear, precise, capable of being tested, should state a relationship between the variables, and must contain an independent and a dependent variable. And in epidemiology, we call these as exposures and outcomes. Operational definition defines the concepts and the labels in context to the objective by the way they are measured. Additionally, these are the definitions of the exposure and the outcome variables of interest. For example, while designing a study on schizophrenia and having an objective, a researcher should define how schizophrenia will be measured in the study, how it will be diagnosed, and how the efficacy will be assessed, for example. If mortality is under study, so how the mortality will be confirmed, for example, maybe with a death certificate, So these are the objectively defined terms called the operational definitions. Let's discuss briefly the epidemiology. So epidemiology, a field of medicine, is the distribution of disease and other health-related outcomes in the population, and the application of this study to control the health problems. The purpose is to understand that the risk factors are associated with the disease, a specific disease, and how the disease can be prevented in the group of individuals. So these are some of the basic terms of, in epidemiology. We study the relationship between the exposure and the outcome with the effect estimates. Based on the sample of research subjects, we calculate the effect estimates. The method of choosing the research subjects is given in the study design. The conclusion in the study are based on the estimated relationship between the exposure and the outcome, and the estimates must be valid to be generalizable. And no study is free from error. In epidemiology, we call them biases. Much can be prevented in the planning phase. So these are the overview of the research designs in epidemiology. I will go through few of them quickly with examples of my recent research publications. The descriptive study involves the systematic collection and the presentation of data to provide a clear picture of a specific situation. These studies can be conducted on a small scale, like frequency studies, or in a large scale, like prevalence and incidence studies. These studies describe the incidence, prevalence of a disease in the large population-based cohorts, or simply describe the frequency of a disease in a hospital-based setting or the pattern or characteristics of the event. The cross-sectional study, it's a survey of a defined population at a single point in time. It is also called a snapshot. A cross-sectional study are also called prevalence studies. They determine the burden of the disease in the population. And always remember that these studies, the exposure and the outcome are determined simultaneously. Population consists of either a small or a defined group called the sample, which is taken from the larger population, and the cross-sectional surveys produce estimates of the prevalence of the population characteristics. This is the design of a cross-sectional study. We gather information about the exposure and the outcome at the same time. Some of those who exposed developed the disease, whereas others did not develop the disease. On the other hand, some of those who did not expose developed the disease, and other unexposed did not develop the disease. Cohort are the observational designs, and they compare the individuals with the known risk factors and with others without the risk factors. This design investigates incidence of a disease over time, and the population estimates are used as the denominators. This is an example of a cohort study establishing incidence of disease over time. This paper is published in the European Journal of Epidemiology in 2017, where I have investigated the incidence of venous thrombosis and its trend over 20 years in Norway. This is another example of the cohort design in which we investigated the incidence of recurrence and mortality due to venous thrombosis, and this paper is published in the Journal of Thrombosis and Hemostasis in 2018. Despite being expensive, time-consuming, and of course, more prone to the selection bias, cohort studies are considered the best because they help examining the rare exposure. They also help to study multiple exposures and multiple outcomes simultaneously in one cohort. And individuals are selected based on their exposure status. And the data is always collected prospectively. This is the design of a cohort study. This is an example of a cohort study design using exposure and the outcome. This paper is published in the Journal of Thrombosis and Hemostasis, in which the hospital related first venous thromboembolism, that was the exposure, and the hospital other factors are also taken as the exposure, and the risk of recurrence is the outcome. Precisely speaking, psychiatric epidemiology studies the distribution and the determinants of ill health frequency in the human beings with the fundamental aim of understanding and controlling the occurrence of the mental illness. Psychiatric epidemiology deals with important components such as disorder distribution and the frequency, determinants of disorder in the human population, and methods employed to control the occurrence of the illness. Traditionally speaking, psychiatric epidemiology lags behind other branches of epidemiology because of difficulties encountered in conceptualizing and measuring the mental disorders. Consequently, modern psychiatric epidemiology continues to be descriptive, focusing on the estimations of disorder prevalences instead of documenting the risk factors and developing the prevention interventions. Descriptive psychiatric epidemiology has gone through extraordinary period of growth over the past decades. For example, starting with the epidemiological catchment area study to the large surveys of adult mental disorders in the general population. Additionally, use of diagnostic interview schedule. This is a fully structured research diagnostic interview, and the methodological studies have reported that diagnostic interview schedule yields reliable and the valid diagnosis. Also, the implementation of parallel cross-sectional surveys of the prevalences and the correlates of mental disorders. Finally, the initiation of research in clinical epidemiology. For example, this medical outcome study, it's a famous psychiatric epidemiological study. And in this study documented that depression is associated with the levels of functional impairment in a wide range of life domains that are comparable to those found among patients with physical disorders such as depression, diabetes, and arthritis. Despite methodological advances surrounding the development of fully structured measures, challenges in this area still remain, since mental disorders are highly stigmatized conditions and many people want to keep them private. Analytical and experimental psychiatric epidemiology are much less well developed than most other branches of epidemiology in psychiatry. This is partly due to the measurement problems and also because of the nature of the causal mechanisms involved in the onset of mental disorders. Nevertheless, important work that has focused on modifiable risk factors for the particular disorders is emerging in analytical psychiatric epidemiology. Examples are obstetric complications to the risk of childhood onset schizophrenia. And my two projects I'm currently working on, which are the maternal mortality in Norway and cardiovascular mortality in mothers after great obstetrical syndromes. I called it as GOS in the last pregnancy. In this project, I have used the population-based medical birth registry of Norway, and I have almost more than 3 million mothers as the sample to explore whether the complications in the last pregnancy might increase the risk of maternal mortality within 1 year. I'm not going into the detail of other GOS factors I have studied because They are not very relevant relevant to psychiatry. However, perinatal death is interesting to discuss here. This includes both stillbirth and neonatal death. We define stillbirth as stillborn infants delivered at 20 to 36 gestational weeks, whereas neonatal death in our study is the death in the first 28 days of life. Infants who die shortly after birth are likely to be included to those exposed to the placental dysfunction. I called it here as abruptio placenta. In this paper, I have calculated the odds ratio because I'm interested in 1 year mortality in mothers giving birth between 1967 and 2000 and had Gauss factors in the last pregnancy. The results show that adjusted odds ratio of maternal mortality within 1 year for perinatal death is 20-fold higher as compared to women giving live birth. You can see the last column, and it is the adjusted odds ratio, adjusted for maternal age and year of birth at last delivery. This means that risk of maternal death within 1 year is highest in mothers with perinatal death as compared to those giving live births. In this paper, I have calculated the hazard ratios because in the second project, I'm interested in the long-term cardiovascular mortality, and that is 53 years as my outcome and the complications in the last pregnancy as my exposure. The adjusted hazard ratios of CVD mortality in mothers after perinatal mortality is 4-fold higher in women with 1 lifetime pregnancy as compared to women giving live births and those who have more than who have women with 2 or more lifetime pregnancies. In simplified way, it means that the risk of CVD mortality is highest in one child mother with perinatal death as compared to those giving live births and those with 2 or more lifetime pregnancies. Analytical and experimental psychiatric epidemiology has gone through various challenges. Majority of adults with serious mental disorders, they experience a series of comorbid psychiatric syndromes that often include a combination of panic, generalized anxiety, depression, phobia, and substance abuse. Analytical investigation of the patterns and determinants of the cumulative syndrome is an understudied area in the development of psychiatric epidemiology. To conclude, we can say that several encouraging advances have occurred in psychiatric epidemiology in the last decades. However, uncertainty and underreporting due to respondent reluctant to admit the symptoms continue to be a major challenge. Additionally, problems exist in studies of special population, including young, the elderly, and the people in the less developed countries. So the take-home message is that psychiatric epidemiologists, they need to develop collaboration with their colleagues involved in preventing mental illness, as well as with policy analysts who are currently in the forefront of developing, implementing, and evaluating the interventions. With this, I thank you, and you all are very welcome to visit the spectacular Norway. And these photographs are taken recently, this not even 1 week from now. And so you all are very welcome with this. This is the most beautiful land in the earth, with this breathtaking, breathless, stunning landscapes. Thank you very much.